Okay, the time now is nearly 8:30. We move to the next presenter. Call upon Dr. Wong Wei Jin, who will be speaking on bariatric surgery in UMMC, where we are now and where we hope to be.
Okay, hi, very good morning to everyone present. Let me just activate the share screen here. So again, very good morning to everyone. Thank you for taking the time out of your schedules to join us in this talk. So I'm Dr. Wong. I'm from the Upper GI Surgery unit. And the topic of discussing today is this, the bariatric service at UMMC, where we are and where we hope to be. I was informed to remind everyone that the questions can go in the Q&A box at the bottom. And for now, we have about 70 participants, so thank you very much. This topic is one that's quite close to my heart, actually. I'm a huge advocate of a healthy lifestyle, and I believe that the weight management is a key component of a healthy lifestyle. Unfortunately, weight management is often misunderstood, and bariatrics has long been seen or has had the stigma of being cosmetic or being a shortcut for patients or for people who do not have the motivation to keep themselves healthy. But now we know that's not the case. So let's go in. So this is the problem. This was a newspaper article. This image was taken from a newspaper article in one of our local newspapers back in 2011. And we can see that at the time, already 44.2% of our population had a BMI of more than 25. Of course, we know that the body mass index is not the be-all and end-all of the measurement of whether a person is overweight or obese. We know that extreme athletes can have very high BMIs, but they're extremely fit. But for the average population, the BMI gives us a pretty good idea of where we are in terms of fitness and in terms of the health. So this was published in 2011, and already at that time, Malaysia was number one. Just not too sure whether it's something we should be proud of, but we were number one in Southeast Asia. And what is slightly more concerning to note is that the definition of overweight here, the BMI 25, is taken from Caucasian data. We now know that for an Asian population, we are generally smaller than our Caucasian counterparts. The cutoff for BMI to be overweight is actually 23. So these numbers actually they underestimate the amount of people who are overweight in Malaysia. So cut to present. This was a newspaper article taken from the New Straits Times in 2016. This was one taken from the Star, also around that time. And both of them already show that Malaysia's obesity rate is now the highest in Asia. So in 2011, we were the highest in Southeast Asia. But since 2016 onwards, we are now the highest in Asia. And this was data that was collected and published in The Lancet in 2016, over here. And it raised some serious questions. Why? It noticed that it pointed out that Malaysia was the largest in Asia. And the big question is why? So anyway, this is the problem. We are the fattest country in Asia, and by quite a fair bit. The second fattest is, so about 50% of our population is overweight. And the second country, or number 2 rank, is surprisingly South Korea with 30%. But we are ahead by quite a bit. So these are slides taken from the National Health and Mobility Survey in 2019. The key findings, it may look familiar to some of yourselves who are in primary care, that sort of thing, who manage chronic diseases. But we can see that the numbers are actually very, very concerning. 1 in 2 Malaysians were overweight or obese. And even more concerning, 1 in 2 Malaysians had abdominal obesity. And we understand now that abdominal obesity is more correlated with metabolic syndrome than it is with just straight up front obesity. Okay, so 50% of us are actually overweight. Excuse me. So this is the problem. We know that obesity and being overweight contributes to metabolic syndrome. And we know that people who are obese they're more prone to diabetes, high blood pressure, heart disease, OSA. sleep apnea, and cancer, all of which are chronic diseases that require long-term treatment, oftentimes with polypharmaceuticals as well and invasive procedures. And what makes it worse is we know that these diseases, they can only be managed chronically. They can never actually be cured. So this puts a huge burden on the healthcare budget. As we all know, the budget has to come from somewhere. And these slides also from the NHMS in 2019, they tally with the slides about obesity. So we are now at a point where 1 in 5 Malaysians have diabetes, 3 in 10, 30% of the population has hypertension, and 4 in 10, 40% have raised cholesterol levels. Putting this together with the previous these two slides, of 50% of our patients, 50% of our population being overweight, it is not difficult to extrapolate that the high numbers of patients with chronic diseases is most likely related or has some very strong associations with the weight. Of the patients that are diabetic, we found that 34 of them are overweight, 30% are obese, which means that if you're of the patients who are diabetic, 60% of them are overweight. And even more concerning, as I mentioned, 77% have abdominal obesity. So again, abdominal obesity being strongly correlated with metabolic syndrome. To make matters worse, again, these are slides from the NHMS from 2019. We can see that the blue and the yellow lines is where the 20% is, the 1 in 5 of people in Malaysia who have diabetes. But 24% of people in Malaysia have impaired fasting glucose. So again, putting together numbers of the 50% of us that are overweight, 24% of us who do not yet have diabetes will develop diabetes sooner rather than later because our fasting glucose is already impaired. So this is the 20%, as I mentioned, the 1 in 5, and the 24% that have fasting glucose. So all in all, something close to 44% of Malaysians have issues with glucose, with sugar. And the 24% I mentioned will likely develop diabetes in the near future. So besides metabolic syndrome, high blood pressure, diabetes, hypercholesterolemia, there's also the problem of obstructive sleep apnea. Because of the impaired metabolism of obese patients, they have supranormal amounts of soft tissue in the necks around the airways, and this contributes greatly to the development of OSA. And as you can see, if the BMI is more than 40%, there's a 50 to almost 100% chance that someone will have OSA. And the relative risk for developing OSA is 10 times that of the normal population. And finally the big C, cancer. Last but definitely not least, we know that there are strong associations between overweight and developing cancer. And all these cancers listed here have been shown to have strong correlations with obesity. The relative risk of developing cancer if you're overweight ranges from between 1.2 to 4. But a 4-fold increase, even a 1.2-fold increase of developing cancer really is something that is worth investigation and is very, very concerning. So these are the problems in a nutshell for our country. Being overweight leads to a myriad of chronic diseases. Medication compliance becomes a problem because of polypharmacy, people getting confused, patients forgetting to take medications because they have so many pills to take. There's an increase in invasive procedures. People with heart disease require angiograms. People who develop diabetic foot will require amputations, dressings, long-term treatment. They require lower limb interventions. And of course, the big question of healthcare economics. There's an increased strain on the healthcare budget. Medications, because of polypharmacy, patients who have OSA requiring CPAP, and of course, cancer treatment. And we all know that chemotherapy, cancer treatment is not cheap at all. And all these are directly correlated to one cause, being overweight. So why do we have this problem? It's multifactorial, of course. Our shift from a very, very agricultural nation to becoming more sedentary, very sedentary lifestyles, poor nutritional education. And what I feel is the most concerning part is this almost acceptance of obesity. In certain cultures, being overweight can be seen as a sign of prosperity, or something that is normal once you get past a certain age. And we feel and we know that actually we should not accept these things because of all the health risks that have been mentioned. The MOH has recognized obesity and being overweight as a priority area, and they have labeled it a research priority area. So the MOH recognizes it, and I think it's time that we really look into it as well. So the solution. So we have the problem. The good thing is we know how to fix it. So the traditional model is, of course, telling someone to diet and to exercise. So although in most people this works very well, but we probably have to wonder why some people claim, or even ourselves, some of ourselves, control our diets very strictly, exercise a lot, but we do not seem to lose weight. And on the other hand, we have people who eat everything, eat all the time, exercise very little, and yet they do not put on weight. So again, for the general population, diet and exercise probably works very well, but there is a subset of population where diet and exercise don't seem to work. And we have that, we've all come across friends, family who claim that I don't eat, I exercise so much, but yet I still am so big. Why is the case? And we know now the answer is actually mainly hormonal. I draw your attention to the right side of the slide, where there are these two things here, ghrelin, PYY, and GLP-1. And these are neurohormonal factors that we now understand to be directly correlated with a patient's weight. Essentially, they set a weight thermostat. So the combination of a patient's ghrelin and PYY tells the body that you should be 100 to 120 kilos. No matter how much the person exercises or diets, they will likely be very unlikely be able to drop below 100 kilos. However, if the balance of ghrelin and PYY and GLP-1 tells the patient's body that you are 50 to 60 kilos, then no matter how much they eat, they tend to maintain that weight. So we know it is not mainly just diet exercise. It's not just a simple equation of calories in, calories out. So bariatric surgery, metabolic surgery, as the name is these days, actually aims to modify these things. We aim to modify a patient's metabolism, a person's metabolism, to optimize the neurohormonal factors that contribute to weight, so that it is not just a matter of diet and exercise, but we can add modifications to ghrelin, PYY, and GLP-1, which will then help a patient to lose weight. So ghrelin, produced mainly by the stomach, it encourages glycogenolysis in the liver, and it actually encourages deposition of adipose tissue. Now, the reasons why we have some people have more ghrelin than others can be very genetic. It used to be a very important hormone in starvation, so that people who had more ghrelin were able to store more fat, and therefore were able to go through long periods of time where they did not have any an access to food. So back in our history, back in the dark ages, 400 or 500 years ago, those with higher amounts of ghrelin were able to get through longer periods of time without food because they had a higher source of fat, as opposed to others who do not. But in the current modern society, where access to food for most of us is not an issue, now ghrelin becomes an issue because it encourages the deposition of fat. So to summarize, ghrelin's two-pronged effects are essentially to make you hungrier and to make you fatter. The second two hormones we look at, PYY and GLP-1. So these are the opposites of ghrelin. So back to this slide, as we can see, ghrelin actually increases your appetite and encourages deposition of fat. But PYY and GLP-1, they do the opposite. They suppress appetite. And those who have higher amounts of PYY and GLP-1, they actually have increased energy expenditure. So both these hormones, PYY and GLP-1, increases the amount of fat that you burn even at rest. So This is what we do in bariatric surgery. We know that ghrelin is mainly produced at the fundus of the stomach. So therefore, in a sleeve, we remove that part of the stomach, thereby removing the stimulation of ghrelin. For PYY and GLP-1, we can increase the amount of PYY and GLP-1 by kind of making a shortcut to the distal small bowel. And when there's increased transit time of nutrients to the distal gut, there's an increased amount of PYY and GLP-1 that will be secreted. And this therefore will increase satiety and increase energy expenditure. So we manipulate the neurohormonal factors that reduce weight by doing this. Two things essentially, either reducing ghrelin or increasing PYY1 and GLP to combine to increase satiety and to increase energy expenditure. So the solution now becomes 3-pronged as opposed to 2-pronged: diet, exercise, and surgery. So moving on to the solution. All these effects have been studied quite extensively in three very large studies done in the Western countries. So this is a sleeve pass randomized trial, and this was done in Finland, published in 2018. And what they found was that after 5 years of surgery, more than half of the patients had lost their excess weight. Again, 45% of patients in the sleeve pass trial had complete or partial remission of diabetes. 60% had discontinuation of cholesterol medications, and 30% had remission of hypertension, which I think is excellent results. So metabolic syndrome, the chronic diseases we have so long associated of being unable to be cured, such as diabetes, cholesterol, and hypertension, we now realize that when they're related to weight, they can be cured by modifying a patient's metabolism. This was the SMBOSS randomized clinical trial. This was published in Sweden, and again, the results are similar to the sleeve pass, where 20% to 30% have remission of diabetes, about the same amount, 30 to 40% had remission of hypercholesterolemia, and half the patients had remission of hypertension. The SMBOSS also looked at OSA, and it found that 20% of patients who were on CPAP were able to come off CPAP after a year. And what's even better is that 30% of them had no more joint and back pain, and 20% of patients reported an improvement in the quality of life as they lost weight. This is the Stampede. This was published in the USA in 2017, and they looked at it one step further. So both the SMBOSS and the sleeve pass, they looked at the procedures itself, but the Stampede decided to compare the procedures versus intensive medical therapy. So if someone is extremely motivated, sticks to a program, takes a medication as well as exercises regularly, comparing this with surgery, and they found quite drastic results. As you can see here in figure A, in patients who just had medical therapy alone, the difference in the HbA1c was quite significantly different in patients who had both surgery and intensive medical therapy. The A1c after 5 years for patients who just had intensive medical therapy was still about 8.5. But the mean A1c for those who had surgery had dropped down to below 7. In terms of BMI, again, after 5 years, the mean BMI was 34 for those who just had medical therapy, but those who had surgery had mean BMIs of 28 to 29. More importantly, I feel, is the remission of diabetes. We can see that after 5 years, for those who had gastric bypass, 45% of them no longer required diabetes medications. For those who had sleeve, 25% came off the medications, and this was after 5 years. So we are able to produce long-term, durable results that show a remission of most metabolic syndrome. So much so that bariatric surgery, metabolic surgery, is now recognized by the American Diabetes Association as a valuable adjunct in the treatment of metabolic syndrome, and is being recommended for a very simple other reason. The single one-off treatment cost has been proven to be more cost-effective than prolonged polypharmaceuticals and prolonged prolonged treatment in the long term. So this is the flow chart that has been recommended by the ADA, the American Diabetes Association. And as mentioned now, so patients with type 2 diabetes, once they've been labeled obese, BMI more than 27.5 for Asians, and they are even class 1 obese patients with poor glycemic control, the American Diabetic Association now recommends metabolic surgery for these patients. Again, due to the very, very durable long-term results that we can see. So that's the problem. And now we talk about the solution at our center. The bariatric service was started back in 2008. Dr. Cha Kar Hui, who has since left our service and is now in private care, and was continued onwards. And the current practitioners of the service here in Malaysia, in UMMC, is myself and Dr. Wong Lai-fen. Dr. Wong Lai-fen is now on maternity, so it's basically me. However, we are not a formal unit. It's run by our team. With the patient at the center, we consider all these things, right? The 6 things: the psychology and education of a patient, the help from a dietitian, pharmacy, of course, sports medicine, internal medicine, and of course, surgery. So with patient-centered care, we individualize our treatment to our patients, and we refer as necessary at this point. So when a patient comes in and we've assessed the patient, because it's run by our clinic, we decide then which specialties they get referrals to. Although it works for now, the problem with this is the patients then have one stack of letters because there's so many people to see. There are multiple letters, multiple appointments, and it is not uncommon for patients to miss appointments because they just get confused with the amount of appointments that they have. And we all know that UMMC is a bit of a maze, and getting lost within UMMC is a real problem for our patients. So moving on to things that we've done before, this is Dr. Pok. So all images that I'm about to show here are patients of ours that have been operated on, and the pictures are taken with their consent. So Dr. Pok was with the upper GI team up to 2015, and these are some of his patients. And I would just like to show you some of the results that we have. This is a gentleman who had a bypass. I can see before and after the difference in his weight. Also, this gentleman had a sleeve gastrectomy, and he lost something like 20 kilos. And we advocated a very healthy lifestyle, which we are quite grateful and happy that he has undertaken. This lady weighed something close to 110 kilos pre-surgery, and she now looks like this. She still comes for a follow-up. We're quite grateful to have her. And this gentleman was pushing 160 kilos before surgery. And after surgery, he dropped down to 80 kilos. And this is actually one of our staff nurses at our clinic. She started at 110, and she's now hovering at about 70 kilos. More importantly, for her, because of her work as a nurse, she has to walk around quite a bit. She no longer has any joint pains. So she's quite happy with the procedure. And I would like to share probably the biggest patient we've done so far at UMMC. This gentleman was pushing 300 kilos when he first came to us, and he was so large that he could not move out of bed, basically. So he had to be extracted with the help of an ambulance service that essentially had to drag him out of bed and to a hospital. He was 300 kilos. And this was the procedure that was being done. You can see how large he is. And it's fully laparoscopic, so minimally invasive. Moving him back onto the bed post-surgery was quite a challenge as well, requiring a lot of people, a lot of help, because at this point he was about, as I mentioned, just under 300 kilos. And this is Dr. Lau, again, one of our consultants that has gone on to private care. And this was the patient post-operatively. And on 4 years follow-up, so he started at close to 280 kilos. He now looks like this. So he's still not normal, essentially. He's still about 110 kilos. But compared to where he was, he's lost a significant amount of weight. And more importantly, he can now walk around, he can now move around. And as you can see, all the excess skin that has since been left along after his surgery. We've offered him referrals to our plastic surgery service to remove all the excess skin, after which he will lose another 20 kilos we feel. But he's not keen for that. So So basically, we have a patient-centered model that has referrals to many, many departments. And we have patients who stay with us for a long time, in which we see very good results. And because of that, we feel that it is truly a very life-changing experience for our patients. So we've talked about those who are very large. How about those in between? So recently we've started to deploy intragastric balloons, which is this. And essentially, it's a balloon that's inserted endoscopically and goes all the way to the stomach and is constrictive and therefore reduces someone's appetite. So the balloon is for patients with a BMI of about 25 to 30, not big enough that it requires surgery, but big enough that you may need some help to lose some weight. And the results seem promising, with patients losing an average of about 10 to 15 kilos at 6 months. The downside of the balloon is that it's not permanent. It has to be removed after about a year. Some patients actually, they come in for yearly changes. So it's like almost like servicing a car. Once a year, they come in and they get the balloon changed. While others, after a year of having the balloon in, because the balloon itself, it acts as a psychological switch, right? It turns on a patient's desire, motivation. And the trigger, the psychological trigger, then motivates someone to lead a very healthy lifestyle. So after a year, when they lost so much weight, they take out the balloon, they actually can stick to a very healthy lifestyle. So, as mentioned, where we are now, we are an ad hoc multidisciplinary team. We're not a formalized service. And we do see some barriers for referral, because there seems to be an uncertainty about the availability of the service in a hospital. There's still a perceived stigma that it is an easy way out. However, like I've mentioned, some patients, they do need help. Diet and exercise alone does not alter the neurohormonal factors that contribute to weight. Of course, there's still a lot of healthcare skepticism about the effectiveness. And what is concerning, as I mentioned, is what we call healthcare provider numbness. We are so used to seeing people who are overweight now that we do not see it anymore. And that is a problem. So currently at UMMC, although we're not extremely high volume, we are happy to report that the volume is increasing. For the past 3 years or so, we've operated between 11 to 14 cases, but just this year, we've done 26 cases already. And we anticipate this number to keep increasing as the service continues to grow. So where we hope to be, so where we are is a informal unit requiring a lot of appointments, requiring a lot of letters, and patients getting lost and getting confused. But we hope to be a formalized unit one day. We hope to have a well-defined pathway for referral. And eventually, as we have larger and larger patients, we will require specialized equipment, such as long laparoscopic instruments, larger OT tables, beds, toilets, commodes, etc., to accommodate patients who are much larger than the current group that we do. So on average, our patients now weigh between 100 to 140 kilos. We occasionally get those who are in their 200s. Our OT beds can accommodate something like 200 kilos. So for the very large patient, which I showed earlier, the guy who had to be dragged out, we actually had to get a special OT bed in so that we could operate on him. So the good thing is that we have a bunch of like-minded individuals in our hospital, and discussions have started for what we call the UMMC weight rehabilitation program. And we hope to be a formalized unit soon. And just these are some of the people that are involved. This is Dr. Chua from gastroenterology, Dr. Lokman, and Prof. Lim from endocrinology, Dr. Haireen from primary care, Prof. Naha from sports medicine. This is Ms. Po, our dietitian, who's very involved with us. And this is Dr. Wong Lifen, and this is myself. So we've had some discussions, and we hope to have a proposal that we can submit up to the hospital administrative staff soon for the formalization of this unit, and to take things forward from there, and to continue to expand our service to help more people. So for now, the service is still being run by us, the upper GI unit. So this is our clinic hours. We are open to referrals, be very open for referrals. If you send patients along with a referral letter, or if you just email me at this address, I'll be more than happy to see the patients and sort them out. So thank you very much. Thank you for joining us. And I think we'll go on to the questions. Okay, so a few questions first. Is there a way to measure ghrelin and PYY? Yes, there is actually. It has been measured mostly in ex vivo models, as well as in animal models. We do not have a commercially available assay at this point. Um, so it's been mainly measured in the context of a clinical trial. I do not think that there is a commercially available assay for PYY and GLP-1 at this point. Hope that answers your question. The next question is from Prof. Kong. Some argue that obesity may stem from childhood, 40% are overweight and rising. When do you think bariatric surgery is indicated, and what is your take on bariatric surgery for kids? Thank you, Prof. That's a very, very good question. At this point, we have a cut off at about 16 years of age. The recommendation is, of course, 18 from the recommendation is 18 years of age from the American Society of Metabolic Surgery. However, this cutoff can be it's not a hard rule. So the youngest patient we've operated at UMMC is actually 16 years old, and currently we have a 15-year-old that we are following up, and we're preparing for surgery. And before we proceed for surgery, actually there's a long discussion with the pediatricians who are involved in the patient's care about when we think the patient's development is complete. So once they've demonstrated tenor stage 4, once the pediatrician has decided that this is as tall as they will grow, then we can open the discussions for surgery. So yes, we do operate on young children, teenagers actually, but it is of course in discussions with the pediatrics team, and the procedures that we do for them tend to be the more minor procedures, so the sleeve gastrectomy as opposed to the bypass, because we do not want the long-term nutritional deficits that can happen with a bypass. The next question, do you think intermittent fasting affects POI and GLP-1? To be very, very honest, I'm not too sure, but what we know is that POI and GLP-1 are released from the distal gut. So physiologically thinking about it, when we do a bypass, what we do is we increase the transit time to the distal gut. And the increased stimulation due to the transit time is what increases POI and GLP-1. So intermittent fasting, unless you can somehow induce some sort of a dumping syndrome, I don't think it will increase POI and GLP-1. If anything, it may decrease PYY and GLP-1. So personally, actually, I'm not a fan of intermittent fasting. I've had this discussion many times with some of my fitness colleagues. I think that it causes swings in insulin levels, and I think it is not as effective. Probably for someone who's not overweight, or he's only just mildly overweight, it will help because of the calorie restriction. But in terms of modification of the neurohormonal factors, I don't think so. The next question, is there ongoing research on further medical manipulation? Yes, there is actually. Just most recently published by the ASMBS, there was a talk by the ASMBS, sorry. The ASMBS is the American Society of Metabolic and Bariatric Surgery. So there was a very interesting talk where they're giving liraglutide, right? So it's the brand name is Ascenda, and it's an appetite suppressor for the most parts. And what they're doing now is they're post-surgery to prevent weight regain. They're administering Saxenda at about 2 years after 2 years after surgery, and we found that this prevents weight regain much more. In Malaysia, there's no research being done in this area yet. I think it's mostly spearheaded by the pharmaceutical companies in America for now. So short answer, yes, there is. Long answer, not in Malaysia yet. Is there any ghrelin inhibitors? I will have to get back to you about this, Dr. Chan. I'm unsure about this at this point, but from what I know in the market, there isn't any. Next question, what about ketogenic diets? Are you for them? So I believe ketogenic diets, they do work, mainly because there is a decrease in amount of carbohydrates, of sugars that a patient takes in. So to a certain extent, I believe it does work. I believe it does work for people who are not extremely overweight, and for those who do not have any form of metabolic syndrome. And I believe that if someone has some form of neurohormonal disbalance, that the things that I've mentioned and discussed, the ketogenic diet will probably work to reduce your weight down to the lower points of what your hormones tell you your weight should be. So for example, again, if someone has a ghrelin level that tells them their weight should be 100 to 120 kilos, the ketogenic diet will probably drop your weight down to about 90 kilos. But to say that to drop it down to completely normal, I don't think that works. But yeah, so for people who only slightly overweight, I think it works fantastically well because of the limitation of sugars. Okay, so I think that's all the questions I have. Are there any other questions? Okay, so if there are no other questions, thank you very much for joining me, and thank you for giving me the opportunity to give this talk. And have a good day to everyone.